Thank you.
Welcome. Good morning, everyone. I hope that woke everybody up a little bit. Welcome to Evaluation and Management of Insomnia and Mental Health and Addiction. We're very pleased to have with us this morning Peter Morgan, MD, PhD at Yale University. Dr. Morgan is an Associate Professor of Psychiatry at Yale University, an Associate Director at Cocaine Research Clinic, Medical Director at the Forensic Drug Diversion Clinic, and the President of the Medical and Professional Staff at the Connecticut Mental Health Center. Dr. Morgan is an internationally recognized expert in substance use and its relationship to sleep disturbances, such as insomnia. He will also report on his use of computerized CBT to treat insomnia and in medical substance use population. Please join me in offering me a warm welcome to Dr. Morgan. We're very pleased to have him here this morning.
Thank you so much. It's really a pleasure to be here and get the opportunity to share some of my insights with you today. So I'm taking this from the perspective of someone who works in mental health treatment. I work at a community mental health center where, in addition to having my research program, I do see patients as well. So I'm going to talk about the evaluation and management of insomnia, and it's from that perspective. But I think what you will find is that most of this is widely applicable and generalizable to most populations. So what I'll do today is I will talk about insomnia, and hopefully a lot of this information won't be 100% new to you, but will be a review. We'll define insomnia and talk about its epidemiology. I'll talk about how you might evaluate insomnia in a primary care setting, and then talk about the treatment of insomnia, largely focusing on non-pharmacological treatment. And at the end, I will share with you some results I have in applying computer-based cognitive behavioral therapy for insomnia in the chronically mentally ill. So a population of patients who suffers from chronic mental illness, could have addiction problems, generally on several medications, indigent, with generally low access to medical and mental health services, and try to show to you that this may be an appropriate intervention for them. So insomnia, what is it? Most people have a pretty good sense of what insomnia is, particularly after you've experienced it yourself, which as you get older, you will have experienced it at some point in your life. And technically, it's defined as a certain set of symptoms. There are symptoms that come in 4 areas: difficulty falling asleep, difficulty staying asleep, waking up too early and not being able to go back to sleep, and then feeling like your sleep quality is poor. So consider these 4 symptoms of insomnia. They become insomnia when they have consequences that affect you the next day. So if someone complains about having difficulty falling asleep but doesn't seem to have any trouble the next day in terms of their function, it's not technically insomnia, it's just having trouble falling asleep. An important thing in the modern age is to consider that insomnia is not insomnia unless the person actually has adequate opportunity for sleep. So another scourge of this nation is the fact that we don't give ourselves enough time to sleep, and we use stimulants and other things to keep us going during the day. So that's what we call voluntary sleep restriction. It may not feel voluntary, but that's what we call it. It's not insomnia. I have listed here on this slide some of the forms of daytime impairment that would qualify you for an insomnia diagnosis, assuming you're having at least one of the insomnia symptoms. And you can see what they are. I bolded at the bottom: concerns or worries about sleep. So if the person is sufficiently worried about their sleep, even though they may be doing okay during the day, that would also qualify them for insomnia. Insomnia has many different subtypes. The thing that a lot of people think they have is primary insomnia, this insomnia that occurs without psychiatric or medical comorbidity that could be related to the insomnia or causing it, not related to drug or medication use. It's not the most common type of insomnia, but it is one that's studied quite a bit because of the cleanness of studying it. So we can talk about primary insomnia a little more easily than the sort of the variety of comorbid insomnias. Chronic insomnia is defined as meeting the criteria for insomnia for 30 days or more. In some cases, people may have insomnia that lasts longer than that, but then resolves, and you might call that an adjustment or an acute insomnia. Most definitions of insomnia, though, have a time cutoff of at least 2 weeks. 30 days is the technical term for chronic insomnia. I'm sure I don't need to tell you this, but insomnia is everywhere, and a lot of people have it. And if you just take at one point in time how many people meet criteria, how many adults meet criteria for insomnia, and it's somewhere between 10 and 20%. So different study methods, different ways of asking about insomnia, but all asking for chronic insomnia of at least 2 weeks duration. It's highly prevalent. And if you're practicing any kind of healthcare, you know this because it's one of the more common complaints. This may be more of a surprise to you, but if you ask people who have insomnia and they say yes, and you ask them how long have you had it, the plurality have had it for 10 years or more. Okay, so they're living a lifetime of insomnia. That their sleep, although they may have brief periods of it being okay, they more or less meet criteria for insomnia most of the time over a long period of time. And what does that mean? Right? Is that just not feeling good during the day? Well, it may mean more than that. All right? It may mean that they're at greater risk for medical problems. And if you just look at the prevalence of medical disorders in persons with insomnia, it's much greater in almost every medical condition that you look at. Insomnia is clearly interacting with both psychiatric and physical health conditions, putting people at greater risk for having more severe problems or more likely to have problems. And it's not surprising that it would also be associated with more significant depression and anxiety. So in this figure, I'm just showing the rate of depression and anxiety, either minimal or no depression and anxiety with the blue bars, or clinically significant in people with and without insomnia. And you can see that in people who don't have insomnia, the rates of clinically significant depression and anxiety are relatively low. And we're really only extracting significant numbers from the people who have insomnia. Most insomnia is what we call comorbid. It used to be called secondary insomnia, the idea that you had some condition that caused the insomnia. That's a little bit of an old-fashioned way of thinking about it, because what we appreciate now, think about the last two slides that I showed, is that the insomnia is not just some end symptom, right? It's not the cough you have from a cold. It's something that is actually contributing to the illness that you're experiencing as well. So we call it comorbid, appreciating that there's a two-way street between what insomnia does and what my other conditions do. And those things feed off of each other and make it worse. And probably somewhere around 90% of us, insomnia co-occurs with some type of psychiatric or medical condition or other sleep disorder. When I treat the primary condition, which I need to do, a lot of times the insomnia persists. Okay, and that's something to pay attention to. Although I want to consider what comorbid conditions there are and treat them, I need to pay attention to the insomnia that may continue despite the treatment. So I'll talk for a few minutes now about the evaluation of insomnia. And this is the type of thing that I would do in my practice in the medical center, the mental health center where I work. Okay, because I would say the majority of my patients at some point, if not regularly, complain about having sleep problems. So I need to be prepared in how to evaluate those problems, how to treat these patients, and how to do it in a way which is hopefully promoting their long-term health and not making my life too difficult. So the basic things, of course, take a good history. Sleep history, I want to document and understand what their insomnia complaints are. I'm going to do it within the context of what insomnia is. So my 4 symptoms of insomnia. And I'm going to ask them more or less what it's like for you living your life trying to sleep. What's it like in your house? What are the conditions before you go to sleep? What are your sleep-wake patterns? Do you have any nocturnal symptoms? These could be psychiatric symptoms, like a panic attack. These could be physical health symptoms, like needing to urinate 5 times in the middle of the night. I want to know very well what those daytime consequences are, because I want to be able to talk to my patient about what's getting better and what's not. Cohabitation factors. People don't live or sleep in a vacuum. Some people share a bedroom or share a bed. Some people share an apartment or a house with people who are on different schedules, who have different needs, and maybe interacting with them. Medical and psychiatric comorbidity, of course. Substance use, have to know about that because of its profound effects on sleep and sleep-wake cycle. And self-treatment. With insomnia as prevalent as it is, and the availability of both over-the-counter and prescription medications, a lot of people have tried to treat their insomnia themselves, either by buying over-the-counter medicines, getting medication from another physician, or very commonly using somebody else's medication to try to help them sleep. My experience is that people don't just offer this information to you. You have to ask and ask pretty specifically for it. If I really want to know how somebody's going to sleep, I need to have them keep a diary of how they're sleeping. Sleep diary is a pretty simple instrument. I'm going to show an example of it, and I usually have my clients fill it out for a couple of weeks. You can base this more on what the frequency you are in seeing the person, but really a minimum of 1 week and better 2 weeks to give you an idea of what their sleep is really like. It's very different to treat somebody who's having poor sleep 1 or 2 nights a week than someone who's having sleep problems every night. And it's hard to get that sense from the person unless you have them really fill it out. People who have sleep problems tend to complain a lot about the sleep, even if it's infrequent. The Epworth Sleepiness Scale is a pretty simple instrument that just gives a sense of how sleepy the person is during the day. This helps me to assess, on the one hand, whether or not that's one of their daytime consequences, but it also helps me keep in mind things that may also be causing sleepiness. If they're very severely sleepy during the day, they may have another disorder, not insomnia. The funny thing about insomnia is that it's really a disorder of hyperarousal. So having a lot of sleepiness during the day is not typical of insomnia. You may get sleepy points during the day, certainly, where people look to stimulants like caffeine to perk up. But as you'll see from the sleepiness scale, there's extremes which indicate something else. So here's a sleep diary, maybe a little bit hard to see, but the idea here is just every day you're asking them to keep track of when they're going to sleep, when they're waking up, whether they had issues with sleep, and how they're rating it. So the other thing that this does is this engages your client in the process of improving their sleep, right? They throw it on to you, doctor, help me, I'm having all this trouble sleeping. And you put it back to them as, I want to help you, but before I can help you, I need to know more. So engage a little bit in your sleep. What I find is that a lot of patients, when they do this, they understand a little bit more about their sleep patterns they're doing, and a lot of them can fix at least some of the problems themselves just by doing this. And the patients who don't want to do it usually don't have that bad of a sleep problem. This is the sleepiness scale, Epworth Sleepiness Scale. Again, it's a pretty simple instrument. There's just sort of 7 situations that you have to rate and how likely you are to doze off in that situation. So if someone's dozing off on a regular basis while they're having a conversation with someone else, that would be considered a type of excessive sleepiness. Probably not normal, probably not related to insomnia. That's more like a sleepiness disorder, maybe secondary to sleep apnea or another condition. But with this scale, it's just a point for each one. Add them up and you get a sense. But just having somebody do this for you, even doing it in front of you or talking about it, can also help you understand, how is this affecting them during their life? So I might use another instrument too, just to get a number. If I'm going to be helping with their sleep, I can do something called the Insomnia Severity Index very quickly with them. They fill it out themselves. It takes them probably about 15 to 20 seconds to do this instrument. It takes you about 3 or 4 seconds to add up the number. So it's not very much of a commitment of time or energy, but it also just quantifies how significant their sleep complaints are. There are more complicated instruments like the Pittsburgh Sleep Quality Index, which takes quite a bit longer to do, but also involves some quantitative things like how much they're actually sleeping. These are the kind of things that I might do at the beginning before I start treatment, and then 2 or 3 months later. You don't want to do them too frequently. For frequent measures, do the sleep diaries. These things are both available online pretty easily. So the thing that I come across most in terms of what maybe I used to do before I actually got into thinking about how to treat sleep, and what I know a lot of clinicians do, because a lot of patients do this, is the sort of the last minute sleep complaint. So in psychiatry, of course, we might have our 30-minute or 45-minute or 15-minute session with a client, and the clients know when that's almost over, and at the end they always throw something at you. Oh, and by the way, and then some terrible thing, right? Or, and by the way, I haven't slept at all for 3 days. You need to give me something. And it's very difficult. They put you in a tough situation, and I can imagine this would happen in a primary medical care setting as well. Go through everything. Oh yeah, and doc, I'm not sleeping. Can you give me something? So the thing you don't want to do is be caught off guard, right? Because when you're caught off guard, you tend to make quicker decisions that are sort of worse in the long run. And the easiest thing to do at those points is probably to just write some prescription for something that you think is not particularly harmful, might help. And that's what I'm trying to tell you today. Try not to do that, right? Be ready with an insomnia severity index or with a sleep diary form. So you can give it to them and say, you know what, that's, I'm glad you brought that up because sleep is a big problem. I'd like to understand that better. Why don't you take these and fill these out for a week or two? Come back and then let's figure that out. Occasionally, your patients do need objective measurement of sleep through polysomnography. So if you're suspicious for sleep-disordered breathing or another sleep disorder like a movement disorder, REM sleep behavioral disorder, they do need that, but it's not a routine part of the assessment of insomnia. So people who are presenting with insomnia, who have insomnia symptoms and daytime consequences, who aren't falling asleep during conversations with their friends, don't generally need polysomnography for you to evaluate and treat their insomnia. So treatment. Treatment for insomnia, all you have to do is go on the internet and you will see the ads on the side of the internet, right? And if you go to enough pages, you'll see that the miracle, treatment, getting a good night's sleep, finally figured out, just click here, right? And I haven't clicked on many of those, but you can imagine what they are. Most of them are selling some type of product, usually that you would take orally, and probably does nothing. But they're out there. And if you go into the pharmacy section of your local, CVS or whatever you have here, there's plenty of things which are for insomnia. Most of them that do anything have similar kind of compounds in them. A lot don't do anything. If you go into the bookstore, in the self-help section, there's always going to be something about improving your sleep. Some of those have elements of things that are helpful. Some of them actually spell out thing that would be like a cognitive behavioral therapy that could be helpful. The thing for us to appreciate is that our patients don't know the difference. They have no idea what that one thing might be actually contain helpful things and one thing won't. And there's so many options, it's very confusing. So if nothing else, be a resource in this regard can be very helpful. It's not some esoteric part of medicine where they're going to rely on you, right? They're going to just see you as one part. You might be telling them something different than what their friends are telling them, what they're seeing on the internet or other places. So it's important to keep that in mind. Other really important thing is that our goal of treatment is not to get our patient to stop complaining. Right? So again, sort of the person leaving the office saying that they're having a sleep problem, you giving the prescription, that gets them to stop complaining at that moment and gets them to leave your office. And they may feel like you've done whatever doctors do, give prescriptions, right? So they may not, even if they're not sleeping better, they may not really complain about it again because they already got what they think they can get from you. Okay, but that's not the goal of our treatment, or at least it shouldn't be. Sometimes it feels like it has to be. But rather it's to improve sleep quality and sleep quantity and to improve insomnia-related daytime complaints. And if we do this, we don't just improve their insomnia, but we potentially improve their medical and physical and mental health. So in terms of how I'm going to approach treatment, I always want to consider the comorbid conditions. For me, that would be addiction, that would be psychiatric problems, that would be both. If a person is addicted to drugs or alcohol and they're using them regularly, a lot of the interventions that I'm going to try to help them with won't work. They won't be able to implement them. So if I can't get them to at least reduce, if not stop using those drugs, it's going to be really difficult. Okay, so I'm going to order for them you know what, let's really talk about your substance use. Where are you on that? What are you prepared to do? If the person has a severe anxiety disorder, right, I'm not sure that the interventions I'm going to do for their sleep are going to be as effective if they're waking up in the middle of the night with panic attacks. Okay, it might help some, but I really want to get that under control the way I know how to at the same time. And same thing with medical problems, chronic pain. This is your area of expertise, not as much mine. But I want to get those things under control. If I can get them to go from waking up 6 times in the middle of the night to use the bathroom to 1 or 2, that's going to really help their sleep. The other thing, really, is cognitive behavioral therapy. I think this is underappreciated in general, that this is the method of treating insomnia. Right? It's the one that's been shown to work in the most situations, the most reliably, and with the best overall results. It's far more reliably shown to help insomnia than any medication. In a way, it's almost like, for me working in addiction, it's like the FDA-approved medications for alcohol dependence. Right? Well, they've actually been shown to work, but for whatever reason, they're not as widely implemented. The reasons there maybe are a little bit different. But cognitive behavioral therapy, when you go to all the guides, say, well, what works, or what are the recommendations? What's, the American Academy of Sleep Medicine, what do they say? They say, this is what you do. Okay? And how many of us are doing that? Right? Well, not many. Right? Most of us have no idea how to do it. Most of us don't think of it, because what we think of as medical providers is writing a prescription. Even though the research shows that prescriptions don't really help with that much. They don't necessarily help long term. They don't cure insomnia. Right? They may reduce complaints about insomnia over a short period of time. Now, I'm not saying that medications are never appropriate, but why would we go first to that when we have something else which has been shown to be consistently effective? So when I do prescribe medications, I do that in the context of supporting the behavioral changes that I'm trying to implement to improve their sleep. Particularly in my clientele who have significant psychiatric problems, sometimes it's necessary. My sense is that in the person who doesn't have psychiatric problems, a lot of times it's not necessary, and perhaps most of the time it's not necessary. So I'm going to give you a little bit of a sense of what the cognitive behavioral therapy for insomnia is. And to understand it, then we want to understand what are the things that contribute to insomnia. So at the bottom, there's this thing called primary insomnia. And as far as we know, like I mentioned, this is a disorder of hyperarousal. So whatever reason, your brain chemistry is just more pumped up on average than the average person. Harder to fall asleep, sleep feels less restful, get less sleep, but don't necessarily feel tired during the day. You may have consequences of the poor sleep, poor focus, other consequences I've mentioned, malaise, but not true sleepiness where you're falling asleep. So sort of tiredness without sleepiness. Maybe it's a good way to say it. So there's lots of factors that contribute to insomnia. At the top, the cognitive factors, things about how we think about sleep. I'll mention that. On the left, homeostatic dysregulation. Homeostatic sleep drive is the drive that says, I've been awake too long, I need to sleep. Okay? So if I do things that reduce my homeostatic sleep drive, like taking a nap, or falling asleep at the wrong time, it can make it hard for me to get good sleep at night. Circadian disruption, so this is my 24-hour clock that says when I should go to bed and when should I go to wake, when should I be awake. If I'm not keeping a good schedule, it can be very difficult to entrain that in a way that allows me to sleep when I want to sleep. And inhibitory factors, things like poor sleep hygiene, and I'll mention each of these things. And for each of these things, there's an element of cognitive behavioral therapy that we can implement, so improving sleep hygiene, doing relaxation therapies, something that we call stimulus control, and sleep restriction. Cognitive therapy, actually directly addressing the thoughts that people have about sleep that are not helpful. If I put these things together, that's what we're going to call cognitive behavioral therapy for insomnia, and I'm going to help most people sleep better and sleep better over a long period of time. CBT for insomnia, it's effective in both primary and comorbid chronic insomnias. It's effective for people of all ages, adults, at least where it's been tested. It's effective in people who are already taking medications to help them sleep. And it should be used initially whenever possible because of its effectiveness and of its general effectiveness. So just go through a little bit of each of the factors that make up cognitive behavioral therapy for insomnia. So these are the kind of information that you'd want to have somewhere not too deep in your memory recesses when you're dealing with patients. Part of convincing them that you can help them sleep better is them believing that you know something about sleep, right? And when you don't feel comfortable with what you know about sleep, you're not going to convince anybody, and they're going to look to other sources. They're going to look to the medications that they're taking or the alcohol. So your sleep environment should be dark, quiet, and cool. Everybody should be exposed to bright light during the day. A relaxing bedtime routine, something that's ritualized and allows people to step down. Imagine what you would do for your children, right? What it takes them to get to sleep. We're not that different, right? If the kid needs to be tucked in and have that story read, sometimes it's only for 3 minutes. Boy, a 3-minute investment to get somebody to sleep well, that's a good investment. So do you have time for that in your life? Do you do these things? Can you tell somebody how to do that? Reducing time in bed. I'm talking more about this because this is an important part of cognitive behavioral therapy for insomnia. It's this time in bed restriction. A lot of people have this strange idea that if they're not sleeping well, they should spend more time in bed to try to get more. All that does is make you sleep worse in bed. Start associating your bed with being awake rather than asleep. Keeping a regular sleep-wake cycle, of course, important. Regular exercise in the morning and the afternoon can also help. Doesn't have to be particularly intensive. The later you do the exercise, the more it might impair your falling asleep. So you want to keep it, several hours before you're planning to go to sleep or more. An easy thing you can tell all of your clients who are having trouble sleeping is take your clock and put it somewhere else. Turn it the other way. Don't let yourself see the clock at nighttime. If you need to wake up with an alarm, that's fine. Have the alarm on, but just don't be able to see the clock. Most of you may have had the experience where in waking up in the middle of the night or having trouble to sleep, you keep looking at the clock to see what time it is and then try to gauge, well, what does that mean? It's, well, I can still get this many hours of sleep. Well, this plus the hour I got before, that would be that, so I won't be so terrible tomorrow. And what you're doing is you're thinking about being awake rather than letting your body relax and go to sleep. Getting rid of the clock. There's one small study, I don't know that's reproduced, but that just one intervention actually had a significant effect on helping people sleep better. Avoiding stimulants. I know that there's probably very few, if any of us in the room, who avoid stimulants completely, but limiting our coffee intake and other stimulants till earlier in the day can be helpful to promote sleep at nighttime, and avoiding bright light during the night. Light is a very funny thing in the way it entrains the circadian rhythm, and light at the wrong time during the middle of the night can really throw you off. So it's important if you do wake up in the middle of the night, sort of one of those little red lamp night lights. It's pretty good for getting around. It won't mess up your circadian rhythm. Sleep hygiene by itself can be helpful, but it's only part of cognitive behavioral therapy, and usually it requires more than just sleep hygiene for people with severe insomnia to get better. Another thing we do is called stimulus control. And this is about associating the bed with sleep. Right? So I want people to see the bed as, that's where I sleep. Right? You can have sex there too, but mostly that's for sleep. What isn't it for? All right, it's not for watching TV. Who does that? Right? I do. Yeah, watch TV in bed. Read in bed. Okay. Now, when I was young, reading in bed was part of that relaxing bedtime routine. The only problem is sometimes if you're not as tired as you should be, and the book is really good, right? There's one thing about reading in bed and sort of falling asleep as you're reading, putting it down, falling asleep. But there's another thing about reading, getting into it, right? And wanting to read more, just one more chapter, and all of a sudden you associate the bed with being awake and enjoying reading a book and not with sleeping. And for people who have problems sleeping, that can make your sleep problems worse. Staying in bed while you're awake. Some people, well, I just lay in bed for like 3 hours. I couldn't fall asleep. That's another thing that's associating being in bed with being awake rather than sleeping. So you may have had the experience or had patients tell you, or as your friends tell you, I'm really tired, and as soon as I get into bed, I wake right up. All right? That's someone who's associated being in bed with being awake rather than being asleep. It's one of the things that we try to fix with cognitive behavioral therapy for insomnia, avoiding napping, going to bed only when sleepy. these are things that fit with that. Now here's this paradoxical thing, or it seems paradoxical to people. And this is where you're really you need to get your patients to really believe you on this one. They've got to try it. You have to really believe it, because this is probably the one thing that more than anything else improves sleep, particularly sleep complaints, because it improves what we call sleep efficiency. Sleep efficiency is what % of time you're in bed you're actually asleep. And people with high sleep efficiency tend to report that they sleep better. And people with low sleep efficiency, even if they're sleeping a lot, tend to report that they sleep poorly. So what do I do? Well, they filled out my sleep diary, and I look at it and I see, you know what? They're sleeping 5.5 hours of sleep, getting 5.5 hours of sleep most nights. But they're in bed for 9 hours, right? So they're waking up and having trouble falling asleep because they actually napped in the late afternoon or early evening. So they can't fall asleep. They finally fall asleep, then they wake up in the middle of the night. They're awake again, and then they sleep in late because they think they need to recover. Okay. So what I'm going to do is say, well, when do you want to get up? And for most people, there's some control in their life that says when they should get up. It's when they have to go to work, when they need to get up for an appointment, when they need to go to school, when their kid gets up, when somebody else they live with is waking up. So we're going to work back from that. You're only getting 5.5 or 6 hours of sleep, right? So you shouldn't spend more than a half an hour more than that in bed. So if you want to wake up at 6 o'clock, let's go to bed at 11:30. What can you do to keep yourself up until 11:30 without stimulants, but through engaging yourself with other people or doing something that's going to keep you awake? I do that. They get into bed, and guess what? They're tired. Right? These people are tired at nighttime. They want to sleep. Their body wants to sleep, and you're just teaching them how to let their body sleep. This is one way to really help, because it really makes them tired. They tend to stay asleep and do well. And if they do well, then you can give them a little more time in bed. You can work it back. Okay, so now you can move to 11. Now, ideally, you want, 8.5 hours in bed? We'll get to that, but slowly. Okay, and they have to follow some of the other rules, of course, napping and other things that you taught them. But this is a widely effective treatment, and it's good for almost everybody. If someone's in a manic or hypomanic state, you don't want to encourage sleep restriction. But other than that, it's a very safe intervention. Now, the other part of cognitive behavioral therapy for insomnia is, of course, the cognitive part. And what you find is that people have a lot of strange ideas about sleep, and the only strange maybe after you realize how bad they are in terms of what they do to the person's sleep. Here's an example with the clock. You can see, I like the one in the, I don't know if this works here. Here in the middle, you see his eyes there. It's very clever, the artist here. The eyes still looking at the clock even with the head the other way. So these are some common insomnia-related thoughts, things that you can help your clients with. When I don't sleep at night, I should sleep in the morning or nap later. Right? Well, actually, just the opposite. What's this going to do? It's going to mess up my circadian rhythm. It's going to mess up with my homeostatic sleep drive. It's going to make it harder to fall asleep the next night, and it's going to perpetuate the sleep problem that I'm having. If I spend enough time lying in bed, I'll eventually feel rested. Okay, I'm guilty of this one. I'm like, well, let me just really relax my body, and even if I can't sleep, maybe that'll help me a little bit. The problem here is that there's nothing wrong with resting, but if you need to be sleeping, you don't want to associate being in bed with sort of quiet wakefulness. You want to associate it with sleeping. Some people think they've lost the ability to sleep. These people are sort of the hopeless type. If you're familiar at all with cognitive behavioral therapy for depression and sort of the cognitive distortions people have with depression, there's overlap here. I can't sleep well because I'm getting older. Getting older does change the way we sleep. So you have to do things slightly differently, but all of these interventions apply the same, and people who are older can still sleep well. A lot of sleeping well when you're older is doing more while you're awake to promote sleep. A lot of people are fixated on a certain number of hours of sleep that they need. And it's true that we do need a certain number of hours to sleep, but it's different for each person. If you do a study of normal sleepers and you restrict them to only get 6 hours in bed each night, after a few days, they're doing really poorly on cognitive tests. There's very few people who need less than 6 hours of sleep to do well. But the range is usually between 7 and 9 hours for almost everybody. There are some people who need more than that, and that's okay. They usually know who they are. When I can't sleep, I need to try harder. Who here has tried to go to sleep? Right? We talk about that. Yeah, I gotta go try to go to sleep. You can hear the tension in the voice. I need to try harder to sleep, man. It's not working out. As you can imagine, this sort of goes against things like the relaxation therapy and these other things that we know help us sleep. Trying to go to sleep doesn't work. Going to sleep is usually more of a cognitive release, not an effort. And people get fixated in the idea that nothing will help them sleep, or even worse, nothing will help me sleep except that little bit of alcohol I have, or that whatever I'm taking, or that drug that I want you to give me. So CBT-i, cognitive behavioral therapy for insomnia, is incorporating all of these things into a treatment program. Okay? And although I don't expect anybody here to become an expert on the delivery of a full package of CBT-i, fortunately we have other ways to deliver that now. Knowing something about that, being able to offer some of it, will help a lot of your clients, and will also prime them for getting a full CBT-i. So part of this is getting people to believe. We know it works because we've done the studies. We see that it works. I want my client to believe that this is the treatment, even though it may take some weeks to really improve, but this is better for you and works better than taking a medication or some other drug. This is a complicated slide, and really I'm just showing this to make a point, all right? Because medications are widely prescribed for sleep problems, very widely prescribed. Very nice study that came out a few years ago. And what it showed is that the CBT, first of all, is effective, all right? Improved people's sleep complaints, improved quantitative sleep measures like total sleep time, sleep latency, time awake after falling asleep, so the time sort of spent awake in bed, and overall sleep efficiency. This is, if you got a study with a medication that showed all of those things, that would be a great find, because studies don't generally show that. Here, the best outcome, this is the point from this slide, the best outcome was in people who got the CBT and stopped taking their sleep medication after the first 6 weeks. So if you look down here in the bottom, this is at a 6-month follow-up, right? All of these people got CBT. These people were allowed to take a sleep medication during that period, and these people were not, okay? So the people who got CBT, all of these people, the ones who weren't given a medication in the long run, did substantially better. So if you are prescribing a medication, and you really think about that before you do, keep in mind that if you really want your patient to do the best, if they're getting CBT for insomnia, which they should be, that medication should stop for the average patient. So I'm going to talk very briefly about pharmacotherapy for insomnia. And ideally, when I give pharmacotherapy, I'm doing it to help my patient make the behavioral changes they need to promote their long-term sleep. Right? So for some patients, because of their anxiety, because of depression, because of other psychiatric issues, maybe because of medical problems, find it very difficult and need support. They need some other reason to do what you're asking them to do. So I might negotiate with them. Say, well, I can give you this. What this will do is, I believe by doing the sleep restriction therapy, you're actually going to be tired and you're going to fall asleep. Your job is to stay awake until that certain hour, okay? And if you get to that point, and if you feel like you're still going to have trouble falling asleep, it's okay. For the first week, you can take this. That's how I might implement it if I'm going to. It's someone who I feel really needs that extra. Most clients don't need that. By doing that, I may allow them to associate, I want them to perceive that it's the other thing that they're doing that's really helping them. The medication is just that little bit to make it a little easier, but it's really the other intervention that's helping. I don't want to prescribe medication in a way that allows them to rely on the medication or think that's what's helping. It can promote adherence to the behavioral change because there's a little bit of negotiation there. They feel like they're getting a little something what they wanted, but they're also listening to you about what you're saying is really more important. It can be difficult to prescribe medications for sleep problems because the sleep medications work on a lot of different receptor systems that may be interacting with other medications that they're taking. A lot of people I see are taking sleep medications, and they're already on other medications that affect the same receptors. And it's no wonder the additional medication isn't working, because you can only hit a receptor so much. And a lot of people are taking sleep medications that have no match to their symptoms, right? So they're having trouble falling asleep, or they're having middle of the night awakenings, or they're not staying asleep, and the half-life of the medication they're getting is all wrong. the time to peak effect of the medication is all wrong. And how many of us really know that and can keep track of it? So the reality is medications are often prescribed to treat the provider, right? Because it's easier for us, gets the person to stop complaining, right? We don't have a lot of time. We need to treat a lot of people. A lot of people are complaining about this, and I've given this medication, and I can give it for a few weeks or whatever, and then I don't usually hear about it. I haven't seen a lot of problems yet, so I feel comfortable doing it. Of course, that's all good until the problem happens. And medications are being prescribed instead of cognitive behavioral therapy, instead of to support it, and they're often prescribed haphazardly. So again, I mean in terms of not in relationship to what the patient's symptoms are, and not keeping in mind what other medications that they're on. This slide's a little bit out of date, but it sends home an important point here too. It's what medications are we prescribing? So this is from, I think, I can't read it now, 2009 was the review. The figure is from earlier, from 2002. Number 1 prescribed medication for sleep, trazodone. Anybody here prescribe trazodone for sleep? Yeah. What do we like about trazodone, right? Seems pretty safe, right? You know, you got to tell something to your male clients, but otherwise you're pretty good about not causing too much trouble with trazodone. And you looked it up, right? And you saw that it was effective in treating insomnia, right? Right. Except that here, number 1 in terms of most commonly prescribed, number of placebo-controlled trials showing effectiveness in insomnia, 0. Okay. Number 2 is a little better, zolpidem. Of course, that's is marketed for sleep, so of course there's going to be some studies. 3 and 4, Elavil, Remeron. Here I'm of course giving the generic names. So you can see that what we're prescribing doesn't have a strong relationship to what's been shown to be effective or what's even been tested in good studies. Okay. So again, to me, this is supporting the idea that we're prescribing to treat ourselves and to treat just the sort of the verbal complaint, the oral complaint that we hear from our patients, and not really to improve their sleep. So if I'm going to prescribe medications, I should know things like time to reach peak blood effect, half-life, receptor binding profile, and drug-drug interactions. Like any medication, it's complicated. Here, it's a little bit more. We're not talking about giving medications that are we're talking about giving a medication to have a specific action at a specific time during the sleep cycle. Okay, so it's not a medication that, well, you could take it in the morning or the evening. It doesn't really matter. It's not that kind of medication. It's medication very specifically for a point in time. So if you're not familiar with these things, it can be really hard to prescribe well, and just puts us in the situation of, first of all, not doing the right things. It's not cognitive behavioral therapy, and 2, potentially doing harm or teaching the person that they're going to need more and more of something to get the effect because we're not prescribing it right. So I have a couple slides just to give an example of this. Here are benzodiazepines and benzodiazepine-like agents commonly prescribed for sleep. And here's some information about their Tmax, the time that they reach peak effect in the blood, effect on the central nervous system, and half-life. So I've highlighted sort of the extremes in half-life here. People do prescribe Valium and Klonopin for sleep. My opinion is a very bad idea, right? Because you're not really treating their sleep, you're treating them the whole day, right? I mean, you're treating them for the next couple of days, right? So why would I want to do that? So I'm just from the little peak I get from when they take the next dose, but keeping this level all the time, probably not a good idea. Sonata is another extreme with a very short half-life. Okay, so if the person's having trouble staying asleep, they're waking up too early, not being able to go back to sleep, Sonata at bedtime is probably not the medication for them. Okay, but I've seen a lot of people prescribe Sonata who that's really their sleep complaint, because the person prescribing is not thinking about it. They're just thinking, oh, well, the Sonata guy came and gave me a nice thing and it seems like it's a good, safe medication, so I'm going to try it. The next 5 people who come in with sleep complaints, I'm going to give it to them. Okay, and maybe I'll help one of them, maybe not. Of course, these medications have potential side effects. Did you hear about Ambien and the reduction in dose, warning about and giving to women because of side effects like these? Antidepressants are commonly prescribed for sleep problems, so trazodone's here on this list. And trazodone has a pretty fast Tmax and has a pretty reasonable half-life. So, I mean, there's a reason it gets prescribed a lot, because it's reasonably safe and reasonably good for potentially treating sleep. It would be nice if there were studies that showed that it really helped. I have over here, these are some of the receptors, the way these medications work to promote sleep. And the thing is, you may be also prescribing medications that affect these systems. Particularly in medicine, looking about this over here. So if someone's already on something that's blocking alpha, giving them a medication for sleep that also blocks alpha is probably not going to do much. And antihistamines, these are the over-the-counter primarily medications that people will use. You want to know about that, that they're using them, and have a sense of how they work. This one here, hydroxyzine, Atarax, Vistaril, probably a lot of you have prescribed that medication. It's also considered something that's sort of safe to give because of low abuse potential, kind of like trazodone. So it gets given to people with substance dependence quite a bit. But look at this Tmax on hydroxyzine, 5 hours. So if a person's having trouble falling asleep, which most people, very common complaint, and I'm giving them hydroxyzine at bedtime, I'm not really treating their problem. Okay, if you were going to do it, well, you should maybe at 7 p.m. or something. So it's sort of starting to kick in at 10 or 11. Like I said, most people they don't appreciate this. It's not out there. It's a lot of information. But anyway, people are prescribing without that information. So part of the message here is you got to be careful. And there's a slippery slope. Once you get started on the path of using medications to treat sleep, particularly in people who have problems with drug or alcohol dependence. Dependence on sleep medication is a real problem. It's associated with dependence on other substances, and it can lead to a collusion between a patient and a doctor that ends up with somebody dead because they started using an anesthesia induction agent to get the person to sleep. The most common, of course, is alcohol. The problem with alcohol is that it may induce sleepiness. Usually that effect wears off within a couple of hours. People are awake. And chronic use of alcohol, and this appears to be true in chronic use of just about every drug that people use chronically, has significant and drastic effects on the homeostatic sleep drive. So people are no longer able to manifest good slow wave sleep and get restorative sleep when they use drugs or alcohol regularly. So before I go into my experience using the computer-based cognitive behavioral therapy for insomnia, just to summarize, we've talked about so far that effective evaluation is critical before initiating treatment. I want to know what my patient's really suffering from so I can direct the interventions that I can do to that. Cognitive behavioral therapy interventions are effective. They have the best long-term outcomes, particularly when medication is stopped. And then that most medications prescribed for insomnia haven't been shown to be effective, don't have long-term benefits, have a lot of potential consequences, and are generally prescribed without appreciation of how that medication would actually help that particular sleep problem. So what should I do? Evaluation of the sleep complaint is often sufficient. Okay, so people who have mild to moderate or infrequent insomnia, by keeping track of the way they sleep, it's part of the cognitive training in a way. Just get them to do that. I can offer from my office, even without a great understanding of this, I can offer some of the things that we've talked about today. If I can highlight one or two things that might work for somebody, they can do that. They can improve, and may also set them up to be more receptive to full cognitive behavioral therapy. And if I want to do that, that's great. But the reality is, where do I find somebody to give cognitive behavioral therapy to my client? Right. Anybody here know you have a referral source for CBT-i? No? Anybody? I don't know either. In my building, it's kind of me. And I try to hide because I can't take that much work. So what about computer-based cognitive behavioral therapy? Where I work, this is really the only option. But I don't know if it's going to work in my clients. So an indigent population with chronic mental illness, this program, Restore, I don't know if you've heard about it, but it's one of these computer-based cognitive behavioral therapies. This one's for insomnia. this was designed so that people, out of the convenience of their homes, could go online and get this treatment. I mean, it's a great idea, right? No need to go somewhere for a treatment, no need to pay somebody for individualized treatment, when the treatment's really manualized anyway. That's what's been shown to work, is manualized CBT. Well, for people where I am, there's really no other option in terms of getting CBT-i. I can't give it to everybody in the center. The clinicians don't know how to do it. They may know a little bit, they can get it started, but not for the severe cases. That's not going to work. Other reasons to do it, medications. We've already talked about pitfalls of medications. From a center standpoint, medications are expensive, particularly when people are prescribing things like Seroquel for sleep. You guys familiar with Seroquel? I've seen patients on Seroquel for anxiety and for sleeping problems. Right? Guess what? That's not its indication. That's an antipsychotic medication. Prescribe it at your own risk. And it's several $100s a month. So I didn't know the program was going to work in my population, though. So I said, well, let's do a study to see whether this program can work in this indigent, chronically mentally ill population. Frankly, I thought in the beginning, I'm not sure it's going to work. I don't know if my patients can sit and listen to this. But I think with the potential benefit of a program like this, you have to try. Say, how generalizable is this program? Is the treatment effective? I know CBT in general is effective in my population. How about CBT-i delivered through a computer? So we did this 6-session CBT-i. We had patients come into the center where they normally come in once a week. Patients who qualified for this program all had insomnia. We used the Insomnia Severity Index, so a moderate or greater level of insomnia. We looked for people who aren't undergoing medication changes at that time, so to be stable on medications for a month to qualify for this study. And we compared them to people who were randomized either to get the CBT-i or treatment as usual. And in both cases, they would come in once a week, fill out our questionnaires, our forms, but the CBT-i group would do the 30 to 45-minute sessions each time they came in. And I was fortunate to get some support from the American Sleep Medicine Foundation. It was actually called the Humanitarian Projects Award to do this. So far, we've evaluated 36 patients. 22 are qualified, and 17 have completed the treatment. And here's just showing the treatment as usual, TAU, versus the people randomized to receive the therapy. And they were well matched in terms of age, education, gender, IQ, and in terms of medications they were taking. Right? Most patients were on a couple of medications. So just to stay basic, do they actually do it? Do they keep coming in? For 6 weeks in a row. We allowed to have one miss and one makeup. Actually, they had a total of 8 weeks to complete the 6 sessions. And the people who were randomized to get the therapy completed at a very high rate. And treatment as usual, you see there was some incentive for actually getting the program. People liked that more. These are people who are used to coming into the center on a regular basis for appointments. Does it help with insomnia? Well, sure enough, it does. Even in this relatively small sample, doing this treatment, looking at before and then after the 6 weeks of treatment, insomnia severity index went from moderate or greater to the mild range in the treatment group with no appreciable change in treatment as usual. So it looks like they're getting something out of it. Look at Pittsburgh Sleep Quality Index, which includes some quantitative measures like amount of time they're actually sleeping, and the same thing. It improves their Pittsburgh Sleep Quality Index scores substantially, and going from, again, moderate to severe to actually in the mild range in terms of sleep problems. The thing I was worried about in the beginning was, would these patients be able to sit and listen to this? Would they get anything out of it? The fact that they got better suggests that they did, but we also asked them, in a way, what did you get out of this? So how easy was this program to understand? And you can see there was a range in what they reported. This is a visual analog scale. So here's the line, and on the left side is nothing, on the right side is a lot, or whatever the anchors might be, depending on the question. And you just put an X on it, and we just measure it. So the average, how easy was it to understand? It's an 82 out of 100. How much of the information did you use? So this would be from none to all, where the middle would be about 50%. And they average about 64, and how helpful was the information for sleeping better, 74. So to me, these puts these two things together. The patients did understand it. They did find a lot of the information, most of the information useful, and they found that that helped them sleep better. And when we looked at their sleep through the Insomnia Severity Index and Pittsburgh Sleep Quality, it was actually better. So this program, it can be administered to patients who are already in treatment. It requires very little staff involvement. I have a research assistant, and all he would do is just show them to the room, turn it on for them, and then he would leave and come back. The patients completed the program at a high rate. They reported using the information that they learned, and they reported better sleep in terms of Insomnia Severity Index and Pittsburgh Sleep Quality Index. So the sample size is so far small. We're still running this study, but the groups were well matched, and it have such a strong effect, a statistically significant effect in that small sample. To me, is very encouraging. So I'm hoping at this point, the center is actually going to start implementing this clinically and not just through research. So we will do that at the mental health center where I work, and we're also looking to expand this to treatment of addiction, depression, and anxiety. So I'll stop there. Thank you very much, and I want to thank the Nicholson Foundation and St. Francis for having me here and supporting us. I'm happy to take your questions.
I wondered, it seemed like there was a sort of a conflict between not watching the clock and then being able to do your sleep better.
Yeah.
There are times on that message. I just wondered whether or not how you put those two things together. It sounds like there was a conflict there too. Whether or not you've done any work in hypnosis or using hypnosis and helping people sleep disturbances.
Sure. So in terms of the clock, the clock is okay when you go to bed. So write down the time, then turn it away from you. And then when you feel like you've decided to wake up for the day, whatever it is, go ahead and take a look. But I can understand what you're getting at. So there's this conflict of, I think I might get up, but I'm not sure. So let me check the clock and see what time it is. And that's actually part of what we want to teach people not to do. Okay. So if we're teaching people that it's important that you get up at the same time every day, then if you need an alarm to help you do that, go ahead. But you don't want to start anticipating, right? Because once you start anticipating, then you'll wake up a little earlier.
But didn't you say something about checking to see how long I was in bed before going to sleep? It doesn't let me have to check the clock.
Yes. Yeah. So, yeah, absolutely. So it is helpful to get some information that may not be therapeutic in the beginning. So we do that. If you think that's a particular problem for the patient you're working with, you would just eliminate that from the sleep diary. I mean, it's part of the assessment, but if you think it's going to be counterproductive, you can take that out. And the hypnosis. So it's part of relaxation strategies. What I do in terms of encouraging people and how to relax better for sleep is not per se hypnosis, but it does involve relaxation techniques which sort of go along with hypnosis, sort of getting people to think about different parts of their body and sort of to sort of loosen up and lose control over parts of their body. So it sort of overlaps a little bit with what some people do in hypnosis, but I don't use it in particular.
Thank you for your talk. I particularly enjoyed seeing on the medication side.
Yeah.
Of course. What do you do with patients who have erratic schedules or work at night?
Well, so the problem with erratic schedules, and you're talking about maybe like shift work, people who are on, the one thing that's been shown over and over again is that no one ever normalizes to a nocturnal schedule. Okay, keeping a nocturnal schedule is always going against what the body drives to do. So even people who sleep, work at night mostly, their body is always struggling and they always have problems with sleep. Shift work is just worse in some ways and better in others. The way that it's worse, of course, is you're really messing up with the circadian rhythm in that you're trying to shift, but it's better. And the reason people do shift work instead of just working night shift is because your body does want to reset to a diurnal schedule. Doing the shift work allows that to happen at least 3 days out of whatever the schedule is. but it's very difficult. Lighting is really important. And so in factories who are run by people who know about this thing will use particularly bright lights for the shifts that are at nighttime or sort of off schedule shifts to help people stay alert. The sleep part is tough, but the staying awake and alert during the time you're supposed to be awake is what we generally focus on, because we can't you can't fix it from the sleep side. You have to let the sleep follow the wakefulness in those regards. So we focus on homeostatic drive, and as much as we can, trying to fool the circadian rhythm, even though we know we can't shift the circadian rhythm that quickly, we try to fool it as much as possible with bright light. And then to try to make the sleep environment that, cool, dark, and quiet is incredibly important, particularly if you're trying to sleep during the day. So, open up the basement room, things like that can be helpful for someone who's trying to sleep off schedule. Avoiding stimulants except towards the beginning of the work cycle can be really important there. The problem with the kind of work that gets done, and we know from working in the hospital, depending on, you may be very tired, but depending on what happens towards the end of your shift, you may be excited from that. Right? You may have gotten an adrenaline rush or something like that, and then there's that cool down period. How many people can go home from a shift at work and fall asleep within an hour? Almost no one. Okay, it's very difficult to sort of come down for that. So you want to really avoid stimulants and other things that would make that harder. Does that help? Yeah.
Thank you, Dr. Morgan. Again, the pharmacological aspect was very good. I have two questions, and one of them is because we, as part of residency, we deal with a lot of inpatient. So is it a good practice to prescribe a PRN medication, sleeping medication for patients that have been in the hospital? And the second question is what to do when you get a call at 1 a.m. and I'm speaking for the residents, the patient cannot sleep. According to the chart that you guys showed us, the quickest acting medication takes anywhere from 1 to 2 hours. So at 1 a.m. you prescribe the drug, you expect the patient to sleep at 3 a.m. and then 5 o'clock the nurse is going to wake him up to take his blood pressure.
Right.
So that's a vicious cycle. So if you can, for the residents, if you can elaborate on that, that would be very good.
Sure. So I really focus the talk primarily on outpatient treatment setting because what data is there out there in terms of what are effective interventions in the inpatient environment. So you're really going off of the hip a little bit with inpatient. But in my opinion, the most important thing is to be preemptive, okay? Because whatever happens at 1 o'clock in the middle of the night, or whatever you do, it's not really going to help, okay? My experience is that most of the time the person was going to fall asleep within an hour or two anyway, okay? So you're treating something, but it's not the person's wakefulness really that you're treating, because that's going to treat itself. But what you really want to do is for the next night to not have them wake up, okay? So, why did they wake up? Or why weren't they able to fall asleep? Do they, because they're having some medical issue, because they're having pain that's not well treated, or they're having trouble falling asleep and I could fix that? Then I absolutely would, and I would try to do it in a way that's going to cover them through the sleep period a little bit better. I mean, so many things go on in the hospital in terms of the stimuli that are there, the lighting, the noise, sharing a room with someone who's having something. There's a lot of things that are out of my control. But what I can do is I can try to also make sure that the medications my patient are getting in the hospital, there's a lot of medications that will make somebody drowsy, that I'm scheduling those to support a daytime, nighttime schedule where they're awake during the day and they're asleep at night. A lot of times that gets missed. And a lot of times the way orders get implemented don't take that into consideration. All right, so I want to consider all the medications. Any medication that might be stimulating, I want to do my best to make sure that gets given in the morning. Anything that's potentially sedating gets given in the evening. If they need to have something that's sedating during the day, I try to decrease the dose that they would get during the day, increase the dose that they would get at nighttime. And so try to do that in advance. And then just keep in mind, whatever happens in the middle of the night, I'm treating myself, I'm treating the staff, I'm giving the patient what might be a placebo. And if it is in the middle of the night, I definitely want to stay away from something that's long acting. Yeah.
It looked like from your chart on the medications that comparing, say, Ambien and Lunesta, Lunesta seemed to have the best profile in terms of a fairly rapid onset and a sort of a long half-life to sort of get people through the night. Did I read the chart correctly? And if you were choosing among those, I know a lot of these benzodiazepine causes sleep disturbances, you use it for long. Maybe they all cause sleep disturbance at the end if they're used chronically. But of those medications, it seemed like Lunesta had, to look down at the chart, sort of the best profile. But I don't know if that's what you found in your practice or not.
To be honest, I don't prescribe these medications. In my practice with my clients, if the patient may, for a variety of reasons, need to be on a benzodiazepine, and if they are, then I will use the benzodiazepine in a way that also promotes sleep. But to my clientele, those medications are too expensive and not effective in anxiety and other things. So part of what I do when I do prescribe is try to use the minimum number of medications. And for me, something like a Lunesta or an Ambien is sort of an additional medication. So I'm not hitting two birds with that stone. So I don't. But yeah, from this chart, you can see it does have some advantages if you're looking at trying to have something that does cover through most of the night. Now, the drawback of having a longer half-life agent, of course, is the potential for next-day effects. Okay, so patients will report more hangover effects from the longer half-life agents. So you have to keep that in mind as well. So the advantage of something like a short half-life agent is that if they just needed to help them fall asleep and then they're sleeping fine, then better chance that it's going to wear off.
A question from online. How would you use the CBT-i model with people who report waking up to intrusive thoughts?
So waking up to intrusive thoughts, the way that question is phrased may not, to my mind, accurately describe what's happening, because the person is waking up and most likely then having intrusive thoughts. So the intrusive thoughts happening during sleep is not the way I would describe it. So I would want to first think about why the person is waking up. Okay, and a lot of times the first reason somebody wakes up in the middle of the night is that their beginning of the night and their end of the night sleep is not matched up. So one of the most common problems, and this is part of why sleep restriction therapy works so well, is that people are falling asleep too early because they're chronically sleep deprived. They're killing their homeostatic sleep drive by sleeping, but then the circadian rhythm, the wakefulness drive, hasn't dropped out in time for them to stay asleep. So let me explain this a little bit better. Our circadian rhythm says we want to wake up at a certain time each day, okay? And maybe 4 hours before that, 3 to 4 hours before that, our circadian rhythm, which keeps us awake, drops out, okay? And that allows us to stay asleep for that second part of the night. What gets us asleep for the first part of the night is the homeostatic sleep drive. So I've been awake all day, I'm tired, all right? Our circadian rhythm actually keeps us awake in the evening, okay? So you know that you have a dip in the afternoon. So the dip in the afternoon is because I've been awake for X number of hours, I should be getting tired, and the circadian drive is low. And that doesn't keep us, it's not keeping us awake very well, and some of us fall asleep in the afternoon. In the evening, the circadian drive comes up, and that overcomes the homeostatic sleep drive, and that's why we're able to stay awake 8, 9, 10 p.m. Now, the problem is the circadian drive that keeps us awake doesn't drop off until later in the night, again, about 3 to 4 hours before we wake up. So if my homeostatic sleep drive puts me to sleep at 9 p.m., but I'm waking up in the morning at 7 a.m., then I have a mismatch. So my homeostatic sleep drive will burn out within a few hours. It might be 12 or 1 o'clock in the morning, but my circadian drive hasn't dropped out yet. So between 1 and 3 or 1 and 4, I can't sleep because I don't have any homeostatic drive to keep me sleeping, and my circadian rhythm hasn't dropped out yet. Okay, that's one of the most common reasons that people are waking up in the middle of the night, why they have trouble falling back asleep in the middle of the night. And the key to solving that is the sleep restriction therapy. Get that bedtime pushed back farther, build up more homeostatic sleep drive, make sure the homeostatic sleep drive doesn't burn out until the circadian rhythm drops down. Now, when somebody's having intrusive thoughts, that can be very difficult. And I'd want to know more about what those intrusive thoughts are. Is this part of a psychiatric condition like anxiety that should be treated independently? Are they intrusive thoughts that come up about sleep itself? Right? Because then some cognitive therapy about the cognitive part of the CBT-i can be helpful for that.
In your study, did you have, what kind of workplace change did you need to make in order to do the study? Did you have one computer, did you have 2 or 3 computers, get them scheduled throughout the day? What were the costs to get your system up and running as you were to get your study done?
Sure. Well, the environment that I'm in is I'm already running research studies and other things, so I already have staff helping me with research. So I didn't actually have to pay anything additional in terms of the staff. I was able to get a room from the center, which I had access to about 18 hours a week. And I had a leftover computer, more or less, that I committed with a nice monitor that I committed to run the program. So there was no cost for me there. And that's all we did. Is one, I think I bought headphones. So I had the patients use headphones for 2 reasons. One, nice quality sound, but also to reduce distractions. It was a single room with a closed door, but it's a busy center, so people walking by. I think those are about $60 or $70. There is some time commitment to screening the patients. So I do a screening process to make sure that they qualify. Now in the center, if this were just offered clinically, then their clinicians could screen them themselves and refer them for treatment. So my staff member did screening, which took about an hour per client.
Is this like a medical assistant that was able to do the screening? Or was it...
Yes, this is a research assistant. So someone who has a bachelor's degree with no particular training, but does have experience working in my laboratory, which means working with people with chronic mental illness and substance dependence. And the program was provided for free as part of the research study, so I didn't have to pay for the program, and that's about it. Yes.
The majority of the patients we see in the clinic, at least, tend to expect a quick fix pill for a lot of problems. I'm guessing the community around Yale would probably be a similar community around Trenton. How open have they been to receiving CBT-i versus pharmacological therapy?
So the patients that I've had have been very receptive to it. Now I would admit that most of them, if they're getting to me, they've already talked about it with their clinician. So there is some level of screening there. I've also had the opportunity to work in a substance dependence treatment, a residential treatment center, where I worked with youths, people who were from about 16 to 20. And my experience there was that a lot of them complained about sleep problems. And the ones who I got to see were very receptive to doing these other methods. And that as much as a lot of them were looking for a quick fix, a lot of them were also looking for some kind of drug to get. And the community sort of supported that in terms of the other clients. It was sort of a game to who could get the medication and who couldn't. But the ones who really had sleep problems were really happy about doing it and were actually happy to not get a medication in the long run for it. But it does require for me to show them my commitment to doing it with them. It's not something, you can't just spend 30 seconds and get them convinced. It might only take 30 seconds to get half of your clients to take a medication, but it takes more than that to get half of your clients to believe that this could be helpful. So you do spend that time, and you show your effort by saying, well, if you fill these out, I'm going to really look at these things. I'm going to really work with you on this. I will take more time, and then it's very effective.
What's your opinion on melatonin?
So melatonin, we know that this is important in the circadian rhythm. Melatonin itself is available, over the counter. The problem with the over-the-counter preparations, there is a wide variety in terms of what you get, in terms of how much. The studies that have been done haven't shown much effect in terms of insomnia. But if you think about, when using melatonin might be most helpful, I think when people are trying to shift their circadian rhythm, then you would imagine that it could be more helpful. And some people do at least report effectiveness in things like jet lag. My experience for jet lag is that stimulants are actually more effective in helping people adjust to the new environment. So this idea of staying awake when you're supposed to be awake in the new hour is more effective than trying to force sleep when you think you should be sleeping. There is a melatonin receptor agonist. If you've heard of this, called Ramelteon, Razorem, and it has been shown effective in a small number of studies, insomnia. And I haven't prescribed it myself. I think that its effectiveness is probably limited, particularly compared to cognitive behavioral therapy, but it does seem to have a pretty good safety profile.
Well, I wanted you to, let's give a very warm thank you for a very excellent presentation.
Thank you.
So pleased to offer